Good morning. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. We have been hosting events over the last month focused on the three MPNs that we pay most attention to, in this case, ET, MF, and PV. We did host programs in MF and PV recently, and today we're going to focus on essential thrombocythemia, or ET. We have with us Doctors Jason Gottlieb and Dr. Katrina Jameson. We would like to recommend that if you have questions, we already have many questions ready for these physicians and researchers, but if you have a question, you can post it on the right under questions, and we will receive that and try to ask as many questions as possible in the 2 hours that we have here. Before we start, I'd like to thank our sponsors. We have many sponsors, our industry partners. You will be hearing from them at the very end of this conference or this program, and they will give updates on their drugs that are in clinical trials, and what's happening in this MPN space is just amazing. I can never say enough about it. I keep thinking I've been in the space for 15 years. It's actually 17 years. And so I'm the old historian here, along with some of the physicians that have been working in MPNs forever. And but I greatly appreciate the two that are joining us this morning. And later, Dr. Linda Razar from Johns Hopkins will be joining us as well. So let me introduce Dr. Jason Gottlieb and Dr. Katrina Jameson. Jason, is, as I said, is with Stanford in Palo Alto, and he has been a frequent speaker in the past when we've been able to meet in person. This is the next best thing and the safest way to do this for now. And then Katrina Jameson is with us. She's with us in voice only, unfortunately, but she is with us, and she will give us a brief update also what's happening at UCSD. But Jason, do you want to go first? Anything that's outstanding right now in your mind that's happening in the essential thrombocythemia space?
Well, and let me start by thanking you and MPN Advocacy and Education International for holding these webinars for patients. I think it's a great service, and spreading the word about MPNs and educating our patients, of course, is very important, and it's always a pleasure to join you and your organization. And of course, it's great to be with Dr. Jameson, who we trained together at Stanford in the early years and 20 years ago. So worked together on several projects, and Dr. Jameson has done a lot for the field. In terms of ET, I would say that there's always a lot of interesting science and clinical trials going on. I think there's a lot of focus on interferons. That's, of course, one of the frontline therapies that one would consider for ET, or certainly as a second-line therapy. I would just bring attention to the fact that ropeg interferon, for example, has been approved in Europe for PV without symptomatic splenomegaly, and there is a trial ongoing now where patients with ET who have been on hydria and resistant or intolerant of it, there's a randomization trial where they get randomized to ropeg interferon or negrolide. So that's an international trial, and I think that certainly that would be an option for patients with ET who have been on hydria and, again, or either resistant or intolerant. And we'll wait for those trial results to occur, but based on the experience with other interferons such as Pegasus, I certainly think that that drug would hold promise for ET. I suspect there will be a lot of questions about interferons and other drugs and reduction of JAK allele burden and how that may modify disease natural history. There's another trial going on with a lysine demethylase inhibitor from Imago Biosciences, and this is a drug that has shown nice responses in patients with MPNs, and because thrombocytopenia is definitely something that we observe with the drug, its use in ET, of course, is very intriguing. So those are two examples of drugs that are in trials and are ongoing right now. I would say that, the future for ET, there's a lot of interest in just novel therapies. So for example, we know that about 20 to 25% of patients with ET have CALR mutations. So I brought this up at the Mayo MPN patient conference, and that is that there are approaches to try to block pathways that are stimulated by the mutant CALR, and that would undergo the categories of, peptides that block CALR, or antibodies that block CALR binding to the thrombopoietin receptor. So vaccination strategies as well. So that's very exciting. That's probably, of course, 5 to 10 years off, maybe a little bit sooner, but I think that's something that holds a lot of promise for patients with CALR mutated ET. I also brought up during that conference that there's a class of drugs called diabodies. Again, I think this is a few years off. These are drugs that basically block the thrombopoietin receptor. The thrombopoietin receptor needs to dimerize. Two legs need to come together in order to stimulate signaling in, for example, megakaryocytes or platelets. These diabodies block the receptor from coming together and also can inhibit signaling and may have an effect on platelets and megakaryocytes, at least in the test tube with cells taken from patients with ET. So this is an exciting therapy, and you can tune these diabodies to modulate the amount of signaling through that receptor. So I think that holds a lot of interesting promise. But again, I think we'll need to await first in human trials in the next few years for that. So, we have kind of active trials and the promise of really interesting therapies within the next few years. So, that's kind of my opening salvo in terms of the hope that exists for patients with ET. I think you're muted, Anne.
And oops. I wonder if we can let her know she's muted.
Hello, can you hear me now?
Now we can hear you, yes.
Okay, great. Sorry about that. I had other people controlling that for a minute. So, Jason, you mentioned some drugs, that are in clinical trials and that show great promise. And because we're constantly updating information about those trials, I'm astounded as to how many are out there and how many are showing promise. But Katrina, can you share with us, or Dr. Jameson, what's happening at UCSD and any ideas and thoughts that you have about essential thrombocythemia specifically?
Yeah, absolutely. I think, this is an incredible field where we work very closely together as a community, driven in large part by the MPN Research Advocacy Group and the MPN Research Foundation. I think that, we can say what we're doing at UCSD, but that seems rather parochial. I think that, we really have to look at the patients who have really given their blood, sweat, and tears for the research and being major advocates for themselves. So I would say that this is an international community. Thank you, Anne, for helping to lead this. In terms of the exciting things that are going on, I think everything that Jason just described is, the way of the future. And I'm very excited to be able to continue to work with Jason and our colleagues in the MPN field to really define at what point do people need treatment. And to me, what I'm most interested in is something that Jason and I started working on way back in 2004, 2005 timeframe. It was published in 2006 in a journal called The Proceedings of the National Academy of Sciences, where we discovered that the JAK2 mutation occurs at the level of the hematopoietic stem cell, whether it was in patients with essential thrombocythemia, myelofibrosis, or polycythemia vera. And Jason would run over with a sample to the building that I was doing my research in at Stanford in Irv Weissman's lab. And we would do this quite routinely. And then Jason would have a Jamocha me crazy kind of frappuccino thing. And I would have my usual chocolate binge. But anyway, there you go. So it was very interesting because we found, and this was by taking individual hematopoietic or blood-forming stem cells from patients, that mutation was there. It was at a higher variant allele frequency. This was actually by sequencing at that time. So it was the first sequencing effort in stem cells in any myeloproliferative neoplasm, or for that matter, any blood cancer. Anyway, so we found that the JAK2 variant allele frequency was higher in polycythemia vera stem cells than ET stem cells. And so we thought, well, wait a minute, maybe the level of the JAK2 mutation of the stem cell matters. So we published that. And then, you know, a number of other groups show that that's true, the JAK2 mutation, but also other mutations like the MPL mutation seem to arise at the level of a stem cell, CALR as well. So what's going on with these stem cells? Well, there were a number of papers that just came out, 2 in Cell Stem Cell, 1 in bioRxiv, that show that the mutations do indeed occur at the level of the hematopoietic stem cell, just as Jason and I and Irv had shown in 2006. But it seems to infer a lineage bias. So what happens in essential thrombocythemia is if you get that mutation at the level of the stem cell, it actually expands the hematopoietic stem and progenitor cell, or the megakaryocyte erythroid progenitor fraction. So I know that sounds like a lot of jargon and people are turning off by this point, but what that means is your stem cells want to become red cells or platelets. And the real question is, when does that happen? So in very clever work done by 2 different groups, one in China and Cambridge working together, the other one primarily at Harvard, they discovered that these mutations occur decades before they manifest in terms of having more platelets. So why is it that some people actually make more platelets or more red blood cells? What is it that's expanding that pre-malignant clone? And it looks like interferon receptor expression may be doing that. So at the same time, actually a little bit earlier, so these papers literally just came up, you know, that these clonal hierarchies exist and that these cells seem to have an advantage in terms of being able to divide without differentiating. That property is called self-renewal, and that actually means the cells clone themselves, but they can't turn the cloning off, so they get an advantage over the period of decades. What my lab did is we wanted to see, why is it that some people select these clones? Is it just that these cells that are mutated in JAK2, CALR, or MPL have the capacity to clone themselves, or is there something else in the person that allows that to happen? And this goes back to a study that Jason did, where he found that quite a few people have the JAK2 mutation, but at a very, very low level. So why is it that some people kind of let that just zoom around in the blood or stay in the bone marrow, and why is it that some people expand that? Well, it looks like the people that expand that clone have a specific immune system that allows them to be tolerant to that clone, and that clone can basically expand because their immune system says, I don't see that. So they have a specific KIR haplotype, killer inhibitory receptor haplotype, a very specific HLA type, and a change in genes that Jason has been studying for 20 years, these epigenetic modifiers, KMT2C, KMT2D, they're actually mutated, and ultimately they mutate inflammatory cytokine receptors. How do we know that? We took 50 people with myeloproliferative neoplasms at different stages, got their blood and their saliva and did whole genome sequencing on sorted stem cells, and we compared that to 100 samples of stem and progenitor cells, and that's how we knew that this is partly a defect with the immune system. And then what happens is some people get a viral infection or chronic inflammation, and that activates an antiviral enzyme called ApoBec3C. That induces C to T mutations, and then to turn that off, another antiviral enzyme called ADAR1 gets turned on. So these aren't just random events. People don't inexorably expand that clone. This is in response, it looks like, to chronic inflammation or even a viral infection. So that's what we just published in Cell Reports. It's an open access journal, so we wanted to make sure that was available to the entire community, and that's what we published in that open access journal. Those data, that paper is available. Thanks, Anne, for posting it there. But also all the data are a dbGaP. We wanted to make this available to all NIH-funded investigators, so the entire data set is there.
That's fantastic, fantastic. Well, we are going to move on to the questions, and we've got lots of them. So you know that we have begun to work with pediatric MPN patients and young adults, and especially in ET, we're finding that many of the parents that come to us with ET patients are female, just happens to be female in this case. But the question is, do younger people with ET have the same life expectancy and risk of progression as those diagnosed in later life? Jason, you want to go first?
Yeah, I mean, I think that's a good question, and I think that pediatric MPNs, which I think, Nicole Cuisine is, a major leader in the field of pediatric MPNs. It's largely, I think, an open field with regard to biology and prognosis, because this is not a very common disease, number one, in adults, believe it or not, although we're biased to think it is because that's what we study and that's what patients are living with. But these are very uncommon. They're very much more uncommon in children and adolescents. And what I would say is this, is that there is a higher proportion of pediatric patients with ET that are what we call triple negative, meaning that they don't have the JAK2 mutation, they don't have the CALR mutation, they don't have a MILPA mutation, and in some cases, it's very hard to know what the mutational driver is, for example, pediatric ET. So that's number one. I think we have to learn a lot more about biology. Number two is that, these MPNs express themselves over decades, meaning that you may start with an ET or a PV, but we always have to think about the natural history of the disease and their evolution. That is, can an ET or PV patient evolve into myelofibrosis or even to acute leukemia? So in adults, for example, if you look at PV, the 10 to 20-year risk of developing myelofibrosis is about 10 to 20%. The 10 to 20-year risk of developing AML in a PV patient is about 5 to 10%. In ET, the 10 to 20-year risk of myelofibrosis is about 5 to 10%, and less than 5% of ET patients over time will develop acute leukemia. But those are 10 to 20-year timeframes. If you're a child, of course, you've got 50, 60, 70, maybe even 80 years ahead of you. And because these evolutions or changes in the disease occur over decades and you've got more time ahead of you, I have to think that there might be more possibility that over that long time span that these changes in the MPN can occur. So that needs to be put into the equation about prognosis. How much time you have ahead of you? What's the runway with regard to how the disease may change over time?
Dr. Jameson, would you like to speak to that?
I completely agree, as usual, Jason, and I think we're picking up more young people, and for some reason, as you mentioned, Dan, particularly women, at least in my clinic, maybe there's a selection bias there, but with ET, and they say, I had migraine headaches going back to when I was in middle school, so that conforms very nicely with the papers that were just published in Cell Stem Cell, the one that is in bioRxiv, suggesting that these mutations arise very much earlier in life. And really the question is, why do some people expand that mutated clone and others not? But what we're seeing is the people that have these mutated clones and activate that enzyme called ADAR1 actually change their splicing. And just how is this related to pediatric AML? What we found in pediatric AML stem cells recently, and you know how vanishingly rare, and so does Jason, of course, that population of patients is, they have a problem with splicing, and actually the pediatric AML patients look a lot more like the adult secondary AML patients that have evolved from MDS or MPNs. So this goes back to Mel Greaves and Tariq Enver, where they did the work on acute lymphoblastic leukemia and found that actually these mutations can be acquired in utero. And so that's what we're interested in seeing in the pediatric AML population. Are they really behaving more like somebody that progressed from an MPN? So what they do is they massively disrupt what's called the spliceosome. They really change splicing, and that makes them very vulnerable to splicing modulators. We also see upregulation in our favorite target genes, Wnt beta-catenin and MYC, as well as MCL1 long and BCL-XL. So what I'm really interested in testing in ET to get much more therapeutic and practical are drugs like navitoclax, NAVITOCLAX. That's a BCL2, BCL-XL antagonist. I think that's going to have activity just as a single agent in essential thrombocythemia and possibly PV, but more so in essential thrombocythemia because platelet production is dependent on that gene BCL-XL. So I think in children, we should be looking for BCL-XL. We should be looking for MCL1 expression and looking to see if we can inhibit those survival pathways. And the real ethical question is, when do you intervene? You know, when is it right to start treatment? And I think that's what the field is grappling with, whether it's in pediatric AML, do we do what Jason's suggesting and really start to detect these clones earlier? I would say yes. I would also say we're starting to pick up these clones in the blood by next generation sequencing. But if you do the bone marrow in these patients, often you find other mutations or that the variant allele frequency is actually higher for the mutation you're interested in the bone marrow. Those stem cells haven't managed to get out of the bone marrow yet. So I know a lot of people with ET aren't having bone marrows. I would suggest that they do because our next generation sequencing panels are getting better. And we're also going to be able to start whole transcriptome sequencing and single cell sequencing in the near future.
Yeah, I would just want to add
Yeah.
to that. And, you know, I haven't read the whole article yet, but one of the articles published in the New England Journal of Medicine yesterday is whole genome sequencing in MDS and AML. And the basic, you know, top line message was that whole genome sequencing is as good or better than chromosome analysis and, you know, single gene sequencing in terms of being informative about the genes or mutations or cytogenetic changes that might impact disease prognosis. So I suspect that we're going to see, because the cost is going to come down more and more, that whole genome sequencing is used as a way to prognosticate in MPNs and other myeloid cancers, and may in fact replace what we're doing now with just, you know, multi-gene panels or chromosome analysis. So I think that's something to look forward to because it looks like it's useful in other diseases.
Fantastic. Good
Just from
news.
Can I add one more thing to that, Anne?
Sure.
If you look at that Jang, the you know paper we just published in that Cell Journal, Cell Reports, it's open access. That's what we found, Jason, that the whole genome sequencing is quite predictive. But the good news is, if you sort the stem cells, their variant allele frequency or mutation burden is actually lower than differentiated cells. The differentiated cells don't matter that much because they're not going to live that long, but the stem cells really have the capacity to repair a lot of these problems in the DNA. So that's good news. So I think if we're going to, I completely agree, we're going to have to do whole genome sequencing, but I would do it at the CD34 positive stem cell level. And that's data that Ludmila Alexandrov pulled out of our whole genome sequencing data sets that were really performed by Human Longevity Inc. That's a company that was founded by Craig Venter, who was the first to sequence the human genome. The reason he did that is he met a patient, and Anne, you've met this patient, who had myelofibrosis, diagnosed in her late 20s, didn't really know what she was going to do with the rest of her life. And she's doing well now on a drug that Jason and I were involved in developing together and published in Cancer Cell 2008, fedratinib. And she's very public about it. But anyway, I think we owe that to this generation.
Fantastic from both of you. Thank you. That is excellent. Excellent answers, and expounding on this is fantastic. This question comes up in the 3 disease areas of MPNs that we focus on, but is ET something I can pass down to my children? Jason?
So the answer is no. So, you know, we think of passing on diseases as, you know, autosomal dominant, autosomal recessive. That's just a fancy way of saying is that there are certain diseases that the offspring has a 1 in 2 chance, 50%, or 1 in 4 chance of 25% of getting the disease. So in that regard, what we call Mendelian genetics, no, this is an acquired disease. It's not something you pass on. Having said that, there are what we call inherited variants in genes, and you know I've talked about this at your seminars, and that can increase the risk of developing these MPNs within families, but the absolute risk is very, very small. So to give an example, we know that the incidence of new diagnosis of PV, for example, is about 2 to 3 in 100,000 individuals. If the offspring of a patient with an MPN in a family inherits certain variants in other genes, that risk goes from 2 to 3 in 100,000 to perhaps 6 to 8 in 100,000. That is still a very, very, very low number. It's not a 1 in 2 chance or 1 in 4 chance like classically other inherited syndromes. So having said that, testing for these inherited variants are not part of the standard of care for the diagnostic evaluation of patients with MPNs.
Katrina?
Yeah, I think that, when we go back to Jason's point about having whole genome sequencing, I actually think that's going to be part of standard of care. You go to your primary care physician, you get your whole genome sequencing. I think it's going to set the baseline for healthcare in our nationally recognized comprehensive cancer centers, as designated by the NCI. So I think that that's coming. What I think is going on is people just have the capacity to really withstand having these clones actually proliferate, and they don't check it. They don't stop it because their immune system goes, yeah, I don't care, And there are other things at play like CD47 upregulation, which is the don't eat me signal. Some people have the propensity to do that. So is that propensity to upregulate a don't eat me signal that the garbage trucks of the immune system called macrophages say, okay, you're fine, keep going, is that inherited? So I think we have to look at inheritance more from the standpoint of the immune system being tolerant to pre-cancer stem cells, or these early clones. And I think that that is probably what's happening. And we'll get into that more as we start to all have our whole genome sequencing done, and then probably have it done at intervals. Do we do this when we all turn 50? Instead of having the colonoscopy, do we actually get our whole genome sequencing? I think that's going to be a standard part of healthcare. And I'm hoping in people that show signs of an MPN, that come in with their visual migraines, they've got paresthesias or, numbness and tingling in their fingertips and toes, and they have a platelet count of 1 million. I hope they get whole genome sequencing. And, ideally it would be at the stem cell level, because they may already have the early signs of myelofibrosis, scarring of the bone marrow, and I would do a bone marrow biopsy in those patients. In terms of, is this inherited? I have had one patient who had the calreticulin mutation, and she said, I think my daughter's got it. I said, I think that's extremely unlikely. She said, you have to test my daughter. I tested her daughter. I said, oh, well, your daughter has a different calreticulin mutation. So her daughter did have a calreticulin mutation. I said, well, it's not inherited from you. She goes, are you sure? Went back and did sequencing on the mom, and she had 2 different calreticulin mutations. One that the daughter had, and then the other one that she had on her own. So, but that's my N of 1. Having seen quite a lot of patients with essential thrombocythemia, clearly that's a rare event. We didn't see that in any of the other 50 patients we sequenced. And, as we put our data sets together, and I hope that this is an outcome from this meeting, and is that we have a central data repository for all of these data sets that the MPN Research Foundation and the MPN Research Advocacy Group actually helps to host. There's my plug.
Yeah, that's great. Yeah. We're trying to get as much information as we can and be able to access that for these purposes. Okay, moving right along, I have page after page of questions here. How frequently does ET progress to PV? I've talked to a lot of patients over these last 17 years, and some will say, well, I have ET and PV. Can you explain that? And then how often do ET patients convert? Jason, do you want to start?
Yeah, I think it's a good question. I'm not sure I have a very specific percentage for you, but I can certainly tell you what to look for in the diagnostic evaluation of that. I mean, I don't think it's common, but it definitely, these occur on a spectrum. ET and PV occur on a spectrum. So, there are very specific diagnostic criteria by the World Health Organization for PV versus ET. And one of the criteria for PV for women is a hemoglobin and hematocrit above 16 and 48, and for men, 16.5 and 49. So certainly if you have that and you have the JAK mutation, in 2021, it's a good bet that you have PV. And of course, we do recommend a bone marrow biopsy to kind of see if the diagnostic criteria are fulfilled. But there are some patients that have high hemoglobins that may just fall short of PV, and maybe they are kind of what I would refer to as a prodromal or not quite yet PV, and there may be in a year or two or a few years, their hemoglobin hematocrit may rise. So it's those patients that don't formally meet the criteria that over time, we just have to keep an eye on them to see whether they evolve into PV. And that makes a difference because that will bear upon whether we would consider phlebotomy for those patients would be a part of the standard care of a PV patient, which we would not do in ET. The other issue is that sometimes one has an ET patient and they're iron deficient, but again, their hemoglobin isn't quite meeting criteria. And it's quite possible that if you're to give them iron, their hemoglobin would start shooting through the roof. I'm not recommending that, of course, but that might be another diagnostic clue that maybe in fact that is an ET patient that is on their way toward a frank diagnosis of PV.
Trina, do you have anything to add to that?
Yeah, now what I'm thinking is these are JAK2 mutation, calreticulin or MPL positive myeloproliferative neoplasms that arise at a stem cell in the environment, the microenvironment and the macroenvironment. In other words, external exposures to viruses and other inflammatory mediators may actually dictate whether somebody makes more red cells or more platelets. So with these mutations, there was a new mutation found in JAK2 in the one cell stem cell paper, and they're really not sure what to do with this one, but it seems to change the capacity of the stem cells to differentiate along the megakaryocyte erythroid lineage. And I think it'll shift based on what we're giving them as treatment, based on whether somebody's iron deficient or not. If you're iron deficient and the megakaryocyte erythroid progenitor says, well, I don't see any iron, I can't make red cells, it's going to make more platelets, particularly if you've got that mutation, the JAK2 mutation, it's going to want to proliferate. So I think that there's more to do with our environment that we have to look into. And, Ron Hoffman made that seminal discovery a number of years ago that a number of patients who lived around the same lake in Pennsylvania near a Superfund site actually had PV. Well, there's got to be something going on with the environment. They weren't related, or they weren't all related. I think if you do statistics, you say, well, maybe that's not significant for the general population, but in a cluster effect, it may well be. So I would get back to what Ron Hoffman had started telling us quite a long time ago. So we live near a decommissioned nuclear plant here called San Onofre. It still emits cobalt-60 cesium-137 that goes into the water and the air. The nuclear rods aren't completely spent. I think that we owe it as a community to look at environmental exposures that may predispose people who are young with PV and ET to progress to myelofibrosis. And, I'd like to look at some of these exposures. The good thing is now with whole genome sequencing, we can look at signatures of radiation exposure. So that's Ludmil Alexandrov. He was at the Sanger at Cambridge for a long time. He can pick up these signatures by our whole genome sequencing. So that's why I really like what Jason suggested, that we should move on to start doing this.
So a couple of things here. First of all, try, if you will, to remember that we're talking to patients and some of them don't know some of the language yet, because many of them are new on this program. But also, that actually Dr. Hoffman and myself went to Pennsylvania. It was a tri-county area. I was approached when I was at the MPN Research Foundation by a group of people in that area, in those counties, and Ron Hoffman and myself. I had called the CDC. They got involved, and we did town hall meetings there. And there was a physician that was from the area who went on to become a physician, went back to the area, and was discovering all these PV patients. And yes, there was over 7,000 tons of toxic waste dumped into a Superfund site there, and or it was identified as a Superfund site after all of the toxins were dumped. And literally in one area that I walked in, because I went on subsequent visits, the grass was spongy with toxins, with chemicals. And it was very sad. It was very difficult. We were able to get, I believe it was $5 million and may have been more during the Obama administration to further study that area. But you also know, and I have to say this, I'm sorry I'm taking this time, but it's important that we have been working with Vietnam veterans who were exposed to Agent Orange and have an MPN. That silo of patients is quite large. And we have a question here from a Vietnam vet that is asking that question of both of you. You know, we only have one study that slightly links Agent Orange to MPNs. We have benzene that we know can cause an MPN or blood cancer. And very often Agent Orange was mixed with benzene to liquefy it. And these guys, mostly men, on the front lines in Vietnam at that time, were told, we have so many stories, but one was cover your armament. While the sprays, they did 6,742 sprays of Agent Orange in different parts of Vietnam and other areas. And they were told to cover their armament, but not themselves. And so I mean, I sit here as a person doing what I do. You two are scientists. I absolutely believe that there is a link, and given the numbers that we see. But could you speak to that, Jason? Do you want to start?
Well, I suspect there may be a link, but you know, the issue is proving it, and that's been not very easy to do. I do know that there is a link between Agent Orange and certain other types of hematologic cancers, such as CLL, but the linkage with the MPNs is a little bit more nebulous. And I think that, you know, we need more data, and it's a little bit challenging because you've got these veterans who are suffering from these diseases, and there is a battle going on about covering their illness and getting benefits. So this is an ongoing issue about trying to accumulate that proof in order to find a linkage. I just don't think we're quite there yet. So there's a lot of frustration, and I empathize with that.
There was a study done at Sloan Kettering, and I forgot the researcher's name. It starts with an L, but anyway, he did do some work, and Dr. Rajit Rampal partnered with us because these vets have all said to us, take our blood, take our saliva, take whatever you have to take to find out if in fact there's a link. And so, you know, we will continue to do our work, but to your point, Katrina, you know, the work we did in Pennsylvania, and you know, it was so obvious. It was so obvious, at least to the novice, to me. But you know, there's radiation coming out of power plants where children live in those areas. Sometimes, you know, there are abnormalities in the pregnancies and so on. So would you like to add anything to what I just shared with you and what Jason said?
Yeah, you know, I have a little bit of a biased view here in San Diego because we live in a military town. And I think that I'm seeing too many young people who are in their 30s with myelofibrosis. Quite a few are Marines, you know, they served. So and they weren't exposed to Agent Orange. So there's clearly more than one exposure that you get when you go into the military. The Department of Defense was actually very interested in this, and they want to dig into why is it that people would get more or seemingly have a slightly higher rate of MPNs in this community. One is with Air Force, they're exposed to a lot of petroleum products. As you know, petroleum is refined with benzene. Number two, they're exposed to what are called burn pits. And so they burn a lot of the equipment, including guns and other things. Three, anybody who served in Desert Storm knows they used uranium depleted bullets because they fly faster, they're lighter. And then four, they're in other environments where they're being exposed to more viruses, they're living in close proximity to each other, and that may trigger these inflammatory responses. The thing is, obviously the DoD wants to look into this. They want to understand whether we're missing something. We were funded to look at that a few years ago. I think now we have the capacity to really dig into this based on the sequencing platforms that we have. We can look at DNA changes from radiation exposure. We can look at benzene-related changes, even pesticide-related changes, as you were alluding to with Agent Orange. The technology didn't exist for that before. But now it's so much better. We can start to ask and answer these questions. It just wasn't possible before, and especially if we link our data sets.
Okay, moving right along. Thank you both for your responses. What signs or symptoms would indicate a potential stroke in ET patients? And I like this question a lot because I had a friend that did have a stroke and never knew it. And so, Jason, do you want to answer?
Sure. So the things that would be a clue possibly of a stroke would be dysarthria, which is the fancy medical way of saying you can't get the words out, or you're trouble getting the words out, although you're thinking of them. You can have basically usually one side of the face or the other come down, so drooping. Okay. You can have an issue with partial loss of vision. You can have issues with loss of motor strength in one arm or the other, or one leg or the other. You can have loss of sensation in one arm or the other, one leg or the other. So loss of sensation, loss of motor strength, inability to get the words out, drooping of one side of the face. Those would be kind of classic symptoms of a stroke. There is another entity called transient ischemic attack, and you can certainly have similar symptoms to that, but the difference between a stroke and a TIA is that the stroke by imaging shows clear vestiges of the incident, whereas a TIA doesn't leave a finding on an MRI or a CT. And I would just mention that a stroke can be a hemorrhagic stroke, meaning bleeding into the brain, or it can be a thrombotic stroke, which means a blood clot in an artery. And that distribution or that territory basically can inform which side of the body, which an arm or a leg is being affected.
And Katrina, anything else to add to that?
I would add it can be pretty subtle, that it evolves over a period of hours, and it can transition from a transient ischemic attack where you don't have permanent damage to a stroke, where you've crossed the line and you're going to have permanent damage. So, just to give you anecdotally, I had a patient who was in her mid-40s, surgeon, felt a little weakness in the left hand, didn't really think about it, was at her Bikram yoga, didn't hydrate well, decided to go skiing at altitude, got major weakness and fatigue, and then, as Jason was mentioning, had difficulty speaking. She had a full-on stroke. Those were the symptoms, though, and what happened was people said, "You're so young, you're so fit, you look so good, it couldn't possibly be essential thrombocythemia." And she did end up having the JAK2 mutation. Her platelet count was in the 600,000 range. She did lose her livelihood as a surgeon because she had permanent weakness in that left hand. So they can be pretty subtle signs, and this occurred over days. So even for a physician, you don't necessarily know what's going on. It's maybe specifically physicians because we tend to be in denial. But they can be pretty subtle signs. The good news is it's reversible sometimes if you go in and you get, well, frequently I should say, if you get hydrated in the ER, you get your MRI, and as Jason was alluding to, these can convert into bleeding, so bleeding around the area of the stroke. That can be predicted and prevented, or at the very least treated. So I would say to people, if you have any of those symptoms that Jason talked about or that I've talked about, go to your ER and get an MRI, and just say, hey, the CT scan's not sensitive enough to see some of these changes.
Yeah.
Dr. Davis' point about, it's all about, we have all around the hospital education about strokes. It's all about getting into an ER as quick as possible. It's all about time from event to treatment if it's a serious stroke in terms of mitigating long-term damage. So thanks, Dr. Jamieson.
Yeah. All right, can you discuss the efficacy as well as the pros and cons of the use of baby aspirin versus hydroxyurea in otherwise healthy patients aged 60 to 65 years old with platelet counts in the 500 to 700 range? Katrina?
That is a very specific question. You know, what I always do, and I know we're getting very technical here, and Jason and I are both on the National Comprehensive Cancer Network panel for MPNs. I usually go through a very detailed symptom assessment scoring to say what other symptoms do they have, and then also I do what's called a von Willebrand factor activity level. So that's the glue that keeps our blood vessels together. Because I really want to know, are they at risk for bleeding if the von Willebrand factor activity level is low? So I usually look at that, and I try and assess, do they have other symptoms? I don't think it's one or the other. You know, it really has to do with the kinds of symptoms they have. And it's interesting, when you start asking people beyond their headaches, when they have essential thrombocythemia and platelets in that range, they've also had numbness in one finger or one toe. They've had these other events. It may not be an entire arm or entire leg, but they go, oh yeah, I thought everybody had that. So once you start getting into the symptoms, it's clear that they do have symptoms of having these platelet plugs forming, and in that case, I would suggest a baby aspirin if their von Willebrand factor activity isn't exceedingly low. If it is low, then we really want to see what's going on in the bone marrow, and has their disease started to progress to early stage myelofibrosis? Are they starting to consume that von Willebrand factor? And then the hydroxyurea is actually in the CytoPV study. It wasn't done in ET. More recently, there was an older study, but in the CytoPV study done by Tiziano Barbui, they showed if you can lower the hemoglobin or hematocrit with hydroxyurea and phlebotomy, people do a lot better. The rate of stroke goes way down. That wasn't done specifically in ET, but you know, I think it tells us we can't be sticking to a number. We really have to go by symptoms, and we have to do a very detailed symptom assessment. So that's what I would say. Jason?
Well, so I just wanted to clarify the question. We are talking about ET. You said a healthy patient with platelets 500 to 700,000.
Right. Yes.
You know, I'm not sure. I don't know about data for a non-ET healthy patient or person with platelets of 500 to 700,000. I would just say that for ET, we do use the algorithms from the NCCN that are aligned with the European Leukemia Net, and that is we divide patients into very low risk, intermediate risk, and high risk. And risk is your risk of future thrombosis. So just very briefly, very low risk is age less than 60, no thrombosis, and not having the JAK2 mutation, that is having a CALR MIPL mutation, for example. Low risk, age less than 60, no history of thrombosis, but yes, you have the JAK2 mutation. Very low risk, we either observe or we could consider aspirin. Low risk because of the JAK2 mutation, which is a mutation that predisposes to a high risk of thrombosis, we do use low dose aspirin in low risk ET, again, less than age 60, JAK2 positive. Intermediate risk, age above 60, no JAK2 mutation, no thrombosis. Those patients we use aspirin, and we have the option of considering hydrea, but in the old times, we used to mandate hydrea. Now there's more room for not considering to use hydrea in intermediate risk. High risk ET is age above 60 and either thrombosis or JAK2 mutation or both. And we do use aspirin and a cytoreductive drug like hydroxyurea or, for example, interferon if it's felt to be appropriate for that patient. So that's how we risk stratify patients, and that's how it directs our treatments.
I would say though, Anne, and I know Jason and I are assuming we're talking about patients with an established diagnosis of an MPN, specifically essential thrombocythemia. As we start to do these targeted sequencing panels and we start to see that people have additional mutations, we're going to start to look at this more carefully, I think, in terms of risk of thrombosis. So if somebody has a JAK2 mutation, TET2, ASXL1, I think we're going to start really needing to revise these strategies for classifying risk. And I would still say that Ruben Mesa's idea of looking at symptoms is extremely important. People may not have had a DVT, but they may have had a lot of symptoms suggesting they may have even had a TIA. And, you know, as we start to dig in a little bit more to histories, I think we're going to get that information.
Yeah, I totally agree. You know, these are guidelines. They're not laws handed down by the gods. And so if you have a low risk or very low risk ET patient, and like Dr. Jameson, Katrina, I can call her Katrina, she's my close friend. You know, if they're very symptomatic, they have platelet-related symptoms, bad headaches, then of course you need to think about what to do to get the platelet count down, and whether it be interferon or hydrea, that would be appropriate. So those guidelines are that, they're frameworks, and we need to look and hear what the patient issues are and pivot accordingly.
I agree. I mean, you're both, I say bravo to both of you because, you know, again, especially in this era of individualized treatments with patients and what's happening with them specifically, I think it's a great point. I would be remiss if we did not talk about the pandemic and the vaccines. And I thankfully was able to get both vaccines, Pfizer drug. This question is kind of interesting because I was very dizzy and sleepy after both vaccines. And actually, I loved how well I slept both nights because I just was out, and it was a very lovely sleep, restful sleep. But this question is, have any ET patients had serious side effects from the Pfizer dose? This patient's hemoglobin dropped from 13 to 10.4 with lightheadedness, GI issues, and nausea that required hospitalization. My understanding is that can happen with anybody. My sister had very similar situation, but was not hospitalized. Either of you who wants to go first?
I mean, I would just, so thank you for that question. I would just say that, you know, your point is well taken, and these, you know, a lot of these are anecdotes, meaning there's no necessarily constant theme that I have heard amongst MPN patients with regard to side effects from these COVID vaccines. And so, you know, there is an effort amongst MPN investigators to basically catalog issues with both COVID and getting the COVID vaccines. We don't have publications yet to really know what the cumulative experience is. Certainly, there's been concern out there about some 30 to 40 cases of ITP, that is immune attack on the platelets. But again, given the number of doses that have been administered, that's still very, very low, and that should not really guide whether someone gets the vaccine or not, at least in my opinion. So I have not heard about a group of symptoms or side effects in MPN patients or ET patients with the COVID vaccines. And I definitely recommend them. Barring a severe allergy or anaphylaxis to vaccines, I do not see another compelling reason right now not to get the COVID vaccines.
And that's the general consensus with all of our docs, all of the researchers. Katrina, do you have anything to add to that?
Yeah, I think this is the most pressing concern for patients with MPNs at this point. Get your vaccine. The Italians did two studies, actually, Passamonte and Barbui, and they both showed higher mortality rates for patients with myeloproliferative neoplasms who obviously weren't vaccinated. This is a study going back several months. I think it's extremely important to get your vaccine. That's all I can say. We are having a special webinar April 8th, 2021 with the Leukemia Lymphoma Society. This is for patients and their families, and it's blood cancer research and COVID. Myself and then Derek Rossi, who was the co-founder of Moderna, and also was at Stanford before and also trained with Irv Weissman. He and I will be talking about strategies to really predict and prevent issues with COVID. It's kind of like love in the time of cholera. It's MPNs in the time of COVID. So I think it's a really important question, certainly the most pressing question that I think we have to deal with clinically now. And I think the most important thing is protect yourself, get vaccinated. Yes, some people anecdotally have side effects. You can treat those with Tylenol or other things, but just protect yourself and your family.
Yes, that's that again. Oops, excuse me, but yes, that's the consensus. We hear all the time, and I'm sure both of you hear this frequently from your patients about neuropathy and arthritis, and Is this person's ET, are there ET symptoms that differentiate from arthritis? You know, is it the ET that's causing the arthritic issues? Is it the arthritis that is messing, you know, similar to ET symptoms? Can either of you just give us an example of, and neuropathy? We have a couple questions here about neuropathy. I remember Bob Rosen had neuropathy really badly in his hands and feet. And when we were working together, he was a PV patient, and but ET patients complain of this as well. Jason?
Yeah, I would say that, we're hematologists, but we're also internists. And I think that the three things you need to think about is, can it be due to a already existing comorbid condition? Is it due to the ET? Or is it due to a drug that we're using to treat the ET? Or is it due to a drug that's treating another comorbid condition? So there's a lot to unpack there. I would say that I'm never dismissive of any complaints that has a hint of being possibly related to ET in the context of a high platelet count, or if the ET patient has a high white count. And so you need to kind of do a diligent internal medicine workup to make sure that you've excluded other causes, whether it be, whether there's diabetes causing neuropathy, whether there's a history of alcohol use. There are other neurologic conditions that can cause neuropathy. In the setting of a high platelet count, you can have neuropathic findings. Sometimes we use the word erythromelalgia, which is a medical term for burning hot feet, and it's due to the sludging of blood in those microvessels that feed the toes and the fingers. And aspirin can be very effective to treat these vasomotor symptoms. And so the aspirin can be a diagnostic maneuver to see whether those symptoms may be in fact related to the high platelet count, and aspirin can help that. But sometimes aspirin doesn't help. It doesn't mean it's not related to ET. It means that maybe you may need additional therapy to try to get the platelet count down and see if the neuropathic findings improve. And if they don't, well, then you may be in the category of maybe this is something else beside ET. And this needs a very much of a fleshing out to see whether you've explored all possibilities. So it can be very difficult sometimes.
And is there a link, Katrina, between hydroxyurea use and neuropathy and arthritis?
And I've been giving hydroxyurea for a couple of decades. I haven't really seen a neuropathy in that setting. To get back to the arthritis question, I was reminded of this yesterday in clinic. If I start seeing people that have arthritis, I really question them. Do you mean bone pain? And more frequently, they actually mean bone pain. And what happens when ET starts to progress to myelofibrosis, myelo means bone marrow fibrosis scarring, you start to get basically expansion of the bone marrow inside because of that scar tissue, and people can sense that. It can be quite uncomfortable. And our friend Paul Frenette actually wrote a paper on pain receptor expression in the bone marrow cavity. It was just published in Nature, which is our top scientific journal. So I think that I want to look to see if somebody's progressing to myelofibrosis. If their main features start to be, wait a minute, I have pain in my joints or pain in my bones.
And I think Katrina's point is great because, is it muscle pain? Is it bone pain? We throw around terms like arthralgias or arthritis, and, that's spot on. And, we always think that, oh, really, that stuff only occurs with myelofibrosis. But, Ruben Mesa has shown that there's a spectrum of side effects that extend from ET to PV and myelofibrosis. And yes, myelofibrosis in its advanced stages tends to be the most symptomatic, but certainly there's a spectrum of symptomology in ET and PV, and we need to respect that and address it.
So Katrina, it is 12 o'clock, and I know that you have to depart, and I so gratefully appreciate your time, and you've been wonderful and always saying yes or trying to be with us as much as possible. And we thoroughly enjoy that and are very happy you've been able to give us this first hour. And so if you need to go, you are free, my darling. And
Great to
It's
see
so
you.
great to see you too, Jinx. It's always great to see friends and stalwart champions for patients. And, you and Jason, Professor Gottlieb, have done a really stupendous job in terms of continuing that thread of, yes, we can make a difference. And I know Linda's going to chime in here and show that that's always possible. So thank you to our patients as well and our friends in the MPN community. I'm going to go to another Zoom meeting, but I look forward to being involved in the future.
Oh, you will be. Thank you so much, Katrina. Have a good day.
Thanks. Bye.
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 And so at this time, I'd like to welcome Dr. Linda Razar from Johns Hopkins. She is joining us now for the second hour and of our conversation about essential thrombocythemia. And I'm going to move on, Linda. Welcome and thank you very much.
Thank you.
And I'm going to ask, we have so many questions, Linda, as I mentioned to you yesterday.
Great.
In our exchange. So a lot of people, and of course there have been studies done about fatigue in MPNs, and that being the #1 issue that patients just talk about. But okay, so I have this horrible fatigue. What do I do about it? First of all, what causes it? And secondly, what can I do to maybe negate some of the fatigue that I experience every day? Linda, would you like to take that?
Sure. So I first want to mention that for the most part, my patients are young adults and adolescents. And I have to say that as a group, this population is probably less affected by, symptoms of fatigue. However, at Hopkins, we have a huge MPN clinic population, and I do get to know some of the older patients. In fact, my mom has MPN, as you know. And so many of the recommendations we provide not only to the young patients who are not having great difficulty with fatigue, but to the older patients who are really a lot of sort of primary care, global health activities that help all of us with energy. And so, one of the most important things is to stay active and to be as active as possible, to maintain a healthy lifestyle in terms of weight management, in terms of diet, and also to avoid things that can foster underlying inflammation, because we think that this underlying inflammation is probably contributing to a great extent to some of the symptoms of fatigue and some of the deleterious consequences of ET. And so things like smoking and things like obesity and diabetes will provide an inflammatory milieu, so will make your body inflamed, and that those things can exacerbate the symptoms of an underlying blood disorder. And so we really strongly recommend all these kinds of activities that would prevent that underlying inflammation. So activity, exercise, and avoiding, smoking and other things that can be pro-inflammatory.
Dr. Gottlieb, would you like to add anything to that?
Yeah, I would just say that, again, Dr. Mesa has shown that fatigue really is the most prevalent symptom in the MPNs. And again, as I talked about with regard to the sorting out of arthritis, I think an internal medicine approach is very important because we tend to have tunnel vision and blame everything on MPNs, which might be true in most or many circumstances. But so again, is fatigue due to the MPN? Is it due to the drug treating the MPN? Is it due to other comorbid conditions? Does someone have a heart condition, a lung condition? Do they have hypothyroidism? Are they on other medications which might be contributing to the fatigue? And so sometimes we use meds for ET like interferon or hydrea, and within a few weeks after starting them, they're just feeling worse, and we think we're doing well by them, but we're causing more problems. So we really need to kind of dissect out the inputs to the fatigue and see what we need to we need to pull off a drug, change a drug, and do more laboratory testing to find out a cause. And I would just finally say that we can't ignore depression or anxiety. So I always ask my patients, and it's always hard to do in a 20, 30-minute meeting, how are you coping with the disease? Are you anxious? What are the things that you're concerned about? Are you depressed? If you are, why? Have you been depressed before? Are you on a medication? Have you talked to anybody? What has been the discussion with family members? That often requires a lot more discussion that a one visit would allow, but maybe sometimes we can just initiate a social worker referral and or referral to our psychotherapy friends if the patient feels it's something that they want to engage in. So again, that's a lot there to unpack, but we really need to make sure that we're looking holistically at the patient and not just the disease.
I agree wholeheartedly. I agree. Can you explain in lay terms what the CALR mutation is?
Okay, I think, is that directed for me?
Take it away, Jason.
Okay, so sometimes it's better to have visuals, but I'll do my best. So we know that in MPNs, including ET, there are too many cells being made, number one. Point number two is that a common thread amongst these disorders is that there is activation of the so-called JAK-STAT signaling pathway. This is just a pathway in the cells that gets activated. Usually it's quiet, it shouldn't be turned on, but it's turned on, and the signaling pathway that's turned on causes cells to divide more, okay? And it's like an antenna on the surface of the cell that it gets hyperactive, sends a signal within the cell, and the cells divide more. Too many platelets, too many red blood cells in PV, too many white blood cells, okay? That signaling pathway is turned on because there are mutations in JAK2, that JAK-STAT pathway, or MPL, for example. MPL is is the receptor that starts the pathway. So those mutations cause the pathway to be turned on, more cells divide. Now, CALR is the third major mutation that we found in these disorders in 2013. And it's interesting is that CALR is a protein in the cell that is geographically nowhere near the JAK-STAT signaling pathway. And so for a few years after it was discovered, people were like, well, in CALR mutated patients, we still see JAK-STAT signaling that's increased, but CALR normally has nothing to do with that pathway. So what's going on here? So it was found that when CALR is mutated in these disorders, it actually adopts or has a new function in CALR, and it is actually geographically misplaced and goes to another part of the cell because of its new function. And it actually, instead of sitting over here, it actually binds to the receptor, the JAK-STAT MPL receptor, and turns it on. So it develops what we call a neo-function, and it has a new function because it's mutated and actually activates the JAK-STAT signaling pathway and causes cells to divide. So I hope that was
I understand.
an appropriate term.
I mean, I've been around a long time and I honestly understand it. Linda, do you have anything to add to that?
No, I think that was a beautiful discussion.
Yeah.
And one of the, I think the really interesting questions about this activation of JAK-STAT signaling is, you know, while we have patients with either JAK or CALR mutations, we see different manifestations of the disease. So some patients have very mild disease, elevated platelets, no symptoms. Other patients have, you know, elevated red cells. And third subset of patients have fibrosis in the bone marrow and scarring, which is a progressive manifestation of these lesions and associated with deleterious events. So we're trying to understand how these similar mutations and similar signaling events can cause different outcomes. And as physicians, we'd like to know that in great detail so that we can provide the best treatments to prevent disease progression.
And I would just want to add to that, you know, a few years ago, there was a plenary abstract at ASH that talked about CALR as a secreted rogue cytokine, which is just a fancy medical way of saying is that this mutated CALR is actually spit out of the cell, secreted out of the cell, and it binds to the receptor causing the JAK-STAT activation. And so why is that important? Because now that we know it's secreted out of the cell, we can actually develop antibodies that bind to it, mop it up so it can't bind to the receptor. So that might afford itself an opportunity to treat CALR mutated patients.
And you mentioned earlier and in a previous program, the vaccine for CALR was discussed. So explain that a little bit to us, please. You know, the vaccine for CALR. You know, if it's already there and supposed to be there, I'm assuming Why would you vaccinate somebody against it?
So what the idea is that when someone has a foreign protein, that's usually shouldn't be mutated, the immune system basically chops up the protein and presents a part of it called a peptide. And then the body basically, the immune cells can present that peptide, causing the immune cells to attack, that peptide so that it's not performing its function. So if you can vaccinate against that peptide that's presented in the person, you can cause basically an immune attack on CALR, preventing it from performing its function.
Linda, anything to add to that?
Yeah, and the only thing I wanted to also point out to that excellent and very clear discussion is that, remember, this mutated CALR is not a normal protein. So when we vaccinate patients, we're coaxing their own endogenous immune system to attack the mutated form of this protein and not interrupt the normal functions.
Okay, that's what I was going to ask next. Thank you. So what happens to it? So my next question is, there are two actually. One is, a lot of our patients want to know about progression or will there ever be a cure for MPNs? Whether, I know there are more MPNs than what we focus on. We focus on the big three, ETMF and PV. And I mean, right off the top of my head, I would say a stem cell transplant or bone marrow transplant has cured some of our patients. That number is growing. More patients that we know are getting stem cell transplants and doing pretty well. I know it's not the end all, and there are many, many issues. But so first, your answers, Linda. We'll start with you. Do you see a light at the end of the tunnel with finding a cure for MPNs?
I think that is a very real prospect, and this is a very exciting field, and that there's been an explosion of research. You've heard about some of the discoveries, the JAK mutation, for instance, the CALR mutation more recently. There has been very promising data with interferon, for instance, that tells us that the mutant genes are being diminished and in some cases even undetectable. So we're very excited about that. The CALR, vaccines and antibodies and other inhibitors are also very exciting. And as you know, in my laboratory, we're studying signal transduction and we're studying downstream epigenetic events, or how the nucleus in our blood cells is altered to make the abnormal inflammatory milieu and cytokines or secreted factors that cause inflammation, why the cells overproduce normal blood cells. And so I think that this sort of research, which can identify factors that are causing those effects downstream of the mutations, and then how we can disrupt them, is very exciting. And so, yes, I do hope and believe that a cure is within reach. I mean, certainly transplantation is a promising therapy. It's effective in a number of people, but it's also associated with significant toxicity. And the people who are most at risk for toxicity are older folks, who are our largest patient population. So many of us are working very hard in the lab to identify what are some of these downstream events that we could intervene with. And I think that a lot of the work that's coming out of many labs is very exciting and promising, and points to potential inhibitors that could be applied to our patients and to prevent progression.
Jason?
Yeah, I think Linda hits a lot of important points there. Transplant we generally reserve for intermediate to high risk patients with myelofibrosis, again, because of the issues of balancing potential benefit and cure with risks. We don't want to necessarily, of course, transplant a PV or ET patient that have many, many years, if not decades, in front of them and expose them to a transplant where we actually may take years off their life. Historically, we have talked about the word cure, where you're several years out of a treatment, you're not on that treatment, and there's no evidence of disease. So that is always, of course, a hope. I'm hopeful. Short of that, there are data, of course, with interferon from Jean-Jacques Kalagian out of France and their colleagues that have explored, well, if patients are on interferon for some amount of time, can you discontinue it? and can you maintain that remission off interferon? So it's kind of what we refer to as a treatment-free remission. And in his study that was presented at ASH, there were certainly a proportion of patients who were on interferon for some time who went off interferon and maintained their complete hematologic remission for months to years. And the two predictors of that were on interferon achieving a complete hematologic remission and achieving a JAK2 mutation burden in less than 10%. So I think there are studies like that that show us what is required to be able to maybe get off a treatment, remain in remission, and short of a cure, being in that treatment-free state and not having any evidence of disease is something that is also something we should try to embrace.
Right. So over the years, I've heard very positive things about hydroxyurea, and there will always, because this is such a heterogeneous group of patients, some do well, some don't. But one overriding thing I hear often is the mouth sores or inflamed tongue, wounds that won't heal, some of those things. Linda, do you have any thoughts or input about hydroxyurea and how, what you've seen with patients in terms of mouth sores?
Sure, yeah. So, because I treat younger adults and older children and even some younger children as well, we tend to avoid hydroxyurea for the reason that it can be mutagenic. It's a drug that interferes with how our cells grow and divide, and in doing so, it's been linked to inducing mutations over time. And so, especially for our young patients for whom we hope have another 80 years to live, we try to avoid therapies that could cause a potential mutation that may cause their disease to progress. Now, that being said, certainly there are some older patients who feel terrific on it. Their disease is controlled, their underlying inflammation is controlled, which in those patients we think comes in part from having overproduction of white blood cells, which can release inflammatory cytokines. So I'm not going to say that it's not for everybody, and that certainly we have patients who have done very well on it. As somebody who takes care of younger patients for whom I hope they have 80 to 100 years left, I try to avoid therapies like hydroxyurea.
Jason, I'm assuming you do have patients on hydroxyurea, and have you seen this before?
Yeah, I have a lot of patients on hydrea. I use it commonly. Certainly the issue of skin and mouth ulcers tends to be dose related. So when we talk about hydrea, if you're on a dose of 500 milligrams to 1,000 milligrams per day, the frequency of that is fairly low. If you're starting to get into hydrea doses of 3 or 4 tablets per day, then you're going to see a higher frequency of this. Sometimes reducing the dose can help, but not infrequently you need to stop the hydrea because the symptoms recur. And the ulcers with hydrea occur in the mouth and they occur in the skin. And when they occur in the skin, they tend to happen around the ankle. And you don't want to get into a situation where you're getting this chronic non-healing skin ulcer. And so you just probably have to change therapy at that point in time. And that's where we would consider, for example, interferon if it's suitable for that particular patient. We may consider a negrolide, and we may consider a clinical trial.
So one of the questions was about a negrolide, and
yeah, it was a good segue.
So can we talk about that? I hear horror stories and I hear good stories about a negrolide, and I think more good stories lately in terms of combination drugs, which we should be talking about as well. But Linda, do you want to? I mean, is this something? Do you ever use a negrolide? Probably not so much with you.
No, we have not used it in our younger patients.
So Jason, what are your feelings about a negrolide? I mean, I'm sure that there are some patients that need it and do well.
Yeah, so I think a negrolide can be a useful drug. So when you talk about a negrolide, first of all, it's a pill. It does have some potential side effects. Every drug has side effects. You just have to know what they are and how to manage them and who not to use a drug in. So a negrolide, the symptoms that we do see can be headaches. It can be diarrhea. It can be lower extremity swelling, or what we call edema. And we tend to try to avoid using it in patients that have known significant cardiovascular disease or arrhythmias. So those would be the major things that we would talk about with our patients. It can be very effective in getting the platelet count down. It can cause blood counts, the white count and the red count, to go down. Perhaps not as much as Hydrea, but we certainly can see it. The history of anagrelide is such that, years ago, it was a favored drug. We would use it as commonly as Hydrea. And then in 2005, Harrison and colleagues published the PT1 trial, which was in the New England Journal of Medicine. It was a trial of Hydrea plus aspirin versus anagrelide plus aspirin in high-risk ET. And the kind of takeaway points of that trial was that Hydrea generally was felt to be the winner in the comparison. Hydrea was better in reducing the frequency of arterial thrombotic events. It was better with regard to tolerance. It was better with regard to the frequency of bleeding. And it was better with regard to, there was less evolution from ET to myelofibrosis in Hydrea plus aspirin versus anagrelide plus aspirin. There were more clotting events in the veins in the Hydrea group, but the number of vein clotting events were relatively small compared to the arterial thrombotic events. So if you take all that data together, again, anagrelide came in second to Hydrea, and in that trial, I think whether it was appropriate or not, gave anagrelide perhaps a bad reputation, which I'm not sure is completely well-deserved. There was a second trial called the anhydra trial, where again they compared Hydrea and anagrelide in ET patients. The use of aspirin was perhaps more variable, and they were found to be equivalent, basically. So you've got one study where Hydrea was better, another study where they're equivalent. Having said that, since then anagrelide has kind of come in as a second-line agent to Hydrea or perhaps interferon. So that's kind of the backstory.
Yeah. So Linda, I have a question here from a young woman who has ET that wants to have a baby. And what are some things that she should be, thinking about and being careful with, and so on? Any advice?
Sure. So we've certainly had many women with MPN, either PV or ET, go through pregnancies and have healthy babies. So that's certainly something that's feasible and realistic. One issue with ET, surprisingly, and some of the patients may be familiar with this, although it's associated with elevated platelet counts, it can be associated with abnormal bleeding, because there's a protein that's important in terms of preventing bleeding, and that's called von Willebrand's factor. And when you have excess platelets, von Willebrand's factor can decrease, and patients can manifest with, women, for example, can have very heavy menstrual bleeding. There can be nosebleeds and easy bruising and bleeding. Now, interestingly, with pregnancy, probably because of the hormonal milieu, von Willebrand factor protein actually increases. So some of these bleeding issues, if they're a problem prior to pregnancy, may in fact be mitigated during the pregnancy. So that's good news. Sometimes we've had patients who have ET, and throughout the course of their pregnancy, their disease can evolve. So it's important, just like any woman who is pregnant, to be in touch with your gynecologist and obstetrician to get careful follow-up, and also to get monitoring of blood counts to be sure that the hemoglobin in particular is at a safe range. The platelet count in general, if a patient doesn't have other cardiovascular risk factors and does not have bleeding from von Willebrand's, we don't worry so much about the absolute number. Now that's much more relevant, I'm sure, in patients that Jason treats who are older and have other underlying comorbidities. But for a healthy younger woman who's anticipating having a baby, many of the general measures that we recommend for all pregnant women, of course, would be important. And in addition, to have blood counts followed. We also, for patients who are on hydroxyurea, we recommend that they stop it several months prior to trying to conceive. In sickle cell patients where this has been used much more, there have been large trials of young women And there have been a few cases where women inadvertently were on hydroxyurea and became pregnant. Now their babies were healthy, but because of the way this drug works, we recommend that people stop that. In terms of a baby aspirin, that can typically be continued, but of course you would want to discuss any therapies that you're on with your obstetrician and your hematologist.
And I do want to say this, that, you know, we stress as an organization that, you know, through pregnancy, through any elective or emergency surgeries, that you bring as many of the doctors together as possible and have conversation, you know, make sure that there's some conversation and understanding about your disease and what it entails and what, you know, what the possibilities are. So thank you. Jason, do you want to add anything to that?
I think Linda mentioned a lot of good things. I would just mention that if there was a drug that was needed during pregnancy, that interferon is generally considered safe for pregnancy. There are some data from the UK group that even PEG interferon seems to be okay during pregnancy. And then the issue of clotting. Certainly if someone has a history of blood clots and then they have a pregnancy, then there would be a discussion about the use of low molecular weight heparin as an anticoagulant during pregnancy, maybe at a prophylactic dose, and then in the postpartum period, where it's a very what we call prothrombotic state, a high chance of getting blood clots. So continuing during and then after some 6 weeks after pregnancy.
Thank you very much. So this is a question that comes up often. Can I take a supplement with my MPN? And the jury's, you know, I hear two sides to this constantly, but is it okay to take vitamins with ET? And if so, which ones? And which foods should this patient avoid? We kind of talked about healthy lifestyle and so on. And I would like to bring this up because a lot of patients do bring this up to us, and that is inflammation, which Katrina talked about a little bit, and you and Linda. So inflammation, you know, I'm supposed to be on an anti-inflammatory diet, which is wonderful food. There's, you know, you really don't have to give up much to be on an anti-inflammatory diet. And I have to say, when I stick to it, I feel great. And so, you know, as far as supplements go in diet, you know, what are your recommendations, and should ET patients take supplements? Linda?
Okay, so first, the mention about anti-inflammatory diets, a Mediterranean diet, which is rich in nuts and fruits and vegetables and fish, is good for everyone, in particular for our MPN patients, because especially ET, if you're worried about thromboses, which can be a important problem, this sort of a diet will help to prevent that and prevent heart disease as well, and also maintain a healthy weight. Now, in terms of vitamins, I'll tackle that one next, and we'll take supplements last. So vitamins, you know, generally a multivitamin is not an unreasonable thing to take. However, for people who may have an elevated hematocrit, sometimes ET and PV can be hard to distinguish. And sometimes you need to actually really distinguish the two, do a red cell mass, which isn't widely available. So if somebody's hemoglobin is tending to be high or on the higher end of normal and has elevated platelet counts and is carrying the diagnosis of ET, you may want to avoid excessive iron supplementation, because that can actually boost the red cell production and increase the hemoglobin, which can be associated with clotting, particularly in young women. So I would be careful with iron, and of course discuss this with your hematologist. Iron studies are reliable and can be checked, and you can know whether or not you really need it. Now, supplements, I always caution my patients, because, you know, people are getting supplements oftentimes on Amazon or at a health food store, and they're really not regulated to the same extent, or sometimes to any extent. And in contrast to the drugs that we use to treat our patients, like interferon, hydroxyurea, all these have to adhere to very strict guidelines before they can be given to patients. And so I always worry about supplements and whether or not they actually are what we think they are, because they're not as closely regulated. So if you are contemplating a supplement, you know, definitely discuss it with your hematologist. and be cautious because, again, they're not regulated to the extent that prescription drugs are. And so while you might think you're getting something perfectly healthy, it may not be what you think it is.
Right. Jason, do you have anything to add to that?
Yeah, I mean, I agree with all of that. I would just add that there are some supplements that, that may increase the risk of bleeding. And in a patient with ET who already may have a predisposition to bleeding, maybe because they have a very high platelet count or they have a von Willebrand defect, you need to exercise caution and talk about the supplements with your doctor. I would just say that, you know, follow a hard, healthy diet. I don't make specific recommendations, in part because, and this is where I guess I'm a little bit prickly, you know, we don't have a lot of data about the role of supplements or certain foods and how it may modify ET. So having said that, we do a lot of things in medicine where we don't have the data and we think it's good, and as long as we're making sure we're not doing any harm to the patient. So whether it be, you know, antioxidants or Mediterranean diet, it sounds like a reasonable and good idea. Do we have substantive data to support it? No, but that's okay. We do a lot of things like that. So let's just be honest with ourselves.
Yeah. Well, I mean, from my perspective, you know, we've started this program called Go with the Flow, you know, meaning the blood flow to help. So foods and herbs and spices that do promote blood flow, that there are studies that, you know, I'm not saying take a turmeric pill every day, because I agree with Linda, and I'm sure you do, Jason. We know that some of these things are just not what they say they are. And but I think just in general, and I think that's what Jason's saying, I think in general, a healthy diet, healthy exercise and lifestyle is obviously going to be beneficial, you know. So but anyway, yeah, it is interesting because we hear a lot of patients want to take supplements and thinking that it is going to help, and sometimes that's very uncertain. Okay, so let me see here. When is a good time and when should a patient have a bone marrow biopsy? Jason?
So, you know, when I started training late 1990s, early 2000s, we Americans weren't necessarily doing bone marrows on patients who we suspected of having ET. We would make it by diagnosis of a high platelet count and excluding other causes for a high platelet count. I would say that the field has moved, and admittedly, I think the Europeans have more than convinced a lot of Americans that as part of their initial diagnosis, we should do a bone marrow biopsy. Why? Well, you want to meet the WHO diagnostic criteria for ET. Well, that's kind of that's not really a reason. It's just kind of more following the lead. I think you want to make sure that you rule out early myelofibrosis versus ET, because it can be a mimic of ET, and early myelofibrosis over time can have somewhat of a change in terms of prognosis from ET. There are some patients with ET that when you do the bone marrow, the chromosome analysis will show some chromosome abnormalities. It's a low percentage, but that might be useful information. So, and the other thing is that, again, there are spectrum of these MPNs. ET and PV can look very similar. So sometimes the bone marrow may actually be more supportive of PV, and the laboratory data may not quite be there in terms of making the diagnosis of PV, but the bone marrow can be suggestive in giving us a little bit of information to maybe keep an eye on the possibility that this is a ET-PV overlap that may declare itself as PV in some amount of time. So otherwise, I personally will do bone marrows when there is some evidence of change in the disease. So what does that mean? It means that the platelet count is either going very high, higher, or lower, progressive anemia, a change in the white blood cell count, a change in symptoms, more what we call myeloid immaturity, which is where in the white blood cell numbers, there are more immature cells like blasts, and a growing spleen. A lot of the signs or symptoms would be suggestive of myelofibrosis, and that would be an indication to do a bone marrow to see if the ET is in fact progressing to myelofibrosis. So that's when I would do it, not just once a year, just to take a look at the bone marrow. I don't want to put my patients through that.
Linda, do you have anything to add to that? Is that
No,
pretty similar to what you do?
I completely agree with that. Yeah, and for our younger patients, sometimes most of the patients that I see actually come to me already having had a bone marrow. But if, for example, we saw a young woman who had a JAK mutation, who had symptoms consistent with PV, and who had an allele burden that was low, and every laboratory test correlated with it, there was no concern over dropping counts, as Jason just mentioned, we may not even do that and just wait and see if there are any of the worrisome hematologic or physical exam signs that pushed us to go further and look deeper.
So is there a prevalence of phlebitis in ET patients, Jason?
So when I hear the word phlebitis, that to me denotes kind of a superficial vein clot or inflammation, as opposed to deep vein thrombosis, deep vein in the leg being clotted, or pulmonary embolism. And the short answer is yes. I mean, we do see it. And the treatment for that, if it were to occur, typically involves aspirin, warm packs, ways to decrease the inflammation. Sometimes if the superficial phlebitis is sufficiently, clinically bothersome or concerning, then we will consider some dose of heparin, Lovenox, to kind of take the edge off the inflammation on a delimited basis, so it's not something you use long term. But the short answer is yes, we see it.
Linda?
I agree completely with all of that. We don't tend to see it as much in our younger patients, but certainly when we do, those measures are all completely, reasonable and can help, improve the process.
Studies have shown that psoriasis increases cardiovascular and thrombotic events. Does this increase clotting risks with a CALR positive patient? Linda?
Well, I think that there's increasing evidence, not only from clinical studies with patients, but also with laboratory models, that any cause of underlying inflammation can really push the disease and cause it to manifest more severely, which can lead to complications. So I certainly haven't taken care of any patients with psoriasis who've had increasing clotting or complications from their myeloproliferative neoplasia, but I think the evidence is very compelling that any underlying cause for inflammation can exacerbate the disease, can make it more manifest, and can worsen, side effects or toxicities from the disease. So we always tell, just as we mentioned earlier, to treat underlying inflammation, to look for those other disease processes, because that will, not only benefit the patient, but may in fact slow the progression of the MPN as well.
So for the sake of time, and I know, Linda, you just jumped on, but I also know you're attending a conference as well. And for Jason, who has been with us since, the onset, I'll go to Jason first and ask you to just give the patients that are watching and listening right now, and this is recorded, so it will be available to others who have not been able to see it today, and to physicians that come to our site and watch these things and that we mail out to. What do you see, what is the hope? I mean, I see lots happening, and we're going to hear from our industry partners in a moment. And there are many that, there's so much going on, but what would you say, your feelings are about essential thrombocythemia in terms of what's coming down the pipeline for these ET patients, anything that is pertinent to them specifically that you would shed some light and some hope on?
Yeah, it's well, thank you for that. And I think the things that I think about, whether it be ET or other MPNs, so this is just kind of thinking off the cuff here. I think it's what do patients care about? That's what's important, and how can we serve them best? So, number one is how do we improve quality of life? how do we improve quantity of life, and basically, how can we make their journey less fraught with anxiety? I think that's important. How can patients with ET or other MPNs have confidence that they're receiving the optimal care? Okay, so, I think that number one is to that latter question, if a patient is being seen by a community doctor, and believe me, community docs or hematologists or oncologists are amazing. They have a full plate of cancers to see, solid tumors and hematologic cancers. They need to know everything. But having said that, ET or PV or myelofibrosis are not necessarily that common relative to solid tumors like breast or lung, colon cancers, prostate cancer. So all I would say is that if you're under the care of a community hematologist and you're getting what you need and you're having your questions answered, great. If for any reason you feel like, or your physician, community doctor feels like you need more help, then yes, by all means, reach out to one of the academic medical centers so we can provide additional guidance. And all of us work closely with community doc to lend a helping hand, review labs, and we're there for you. So I want you to know that. So any patient should not be concerned about seeking a second opinion. You need to be an advocate for yourself, and a la MPN Advocacy and Education International, you need to be an advocate for yourself and not be worried about what your doctor thinks about getting a second opinion. So that's kind of the first part of the journey. The second part of the journey is after establishing a diagnosis, making sure your questions are answered. What is my prognosis? And again, making sure you get the answers you need from either a community or academic hematologist. So what does that journey look like? What is my risk of thrombosis? What is my risk of bleeding? What is my risk of evolution to myelofibrosis? What is the chance I get acute leukemia? Is it inherited? Will I give it to my children? How often do I need to see you? When do I need to get my labs? Again, your community doctor or your academic hematologist, oncologist should be able and willing to provide those answers for you. Treatment. Some patients don't need any treatment, and that's a good thing. But having said that, the idea of carrying a diagnosis of having the sword of Damocles hanging over your head, not knowing when things are going to change or why don't I need treatment? I have this condition and I don't feel bad, but my platelets are 700,000. How can that be? Well, we as doctors need to explain that to patients, why it's okay to wait and watch and observe without giving treatment. There are many treatments that have shown in early phase disease not to do anything to modify the natural history. So treatment is not always the answer. But that goes to, when do I need treatment? And we need to explain to our patients basically what are the issues that require me to be treated. And we need to explain that to our patients. High platelet counts, symptoms, evidence of evolution to myelofibrosis. So we need to explain that. I think that moving forward, I'm very hopeful. I think that we, of course, need to focus on quality of life. We need to focus on symptoms, but we also need to focus on how we can modify the natural history of the disease such that we give hope that we can push myelofibrosis further in the future. We can push acute leukemia further in the future so patients don't have to worry about, and that we can somehow come up with therapies that actually do improve overall survival. We often say that patients with ET enjoy a survival that is similar or near similar to matched age-matched controls. But, there is a potential decrement in survival for patients with ET, and we need ways to see if we can modify that. So, drug companies, us academics, community doctors, are all working together to try to basically achieve those goals. And, whenever I go to the American Society of Hematology meeting every year, I am just literally blown away by how smart and innovative drug development is for whether it be MPNs or sickle cell anemia, other blood diseases. I am so impressed that I'm really excited for the future of ET. So I want patients to be hopeful because I'm very hopeful, and I really do think we're going to make major advances in the next 5 or 10 years, whether it be with targeted agents. As we learn more about genome editing, improvements of transplants, there is a lot of hope out there, and I really want to relay that message.
I agree with you wholeheartedly. Linda, what last thoughts do you have for our patients?
Well, first, thanks so much for this opportunity. And I want to echo what Jason said. I think the future is really exciting. In fact, the seminar that I was just at and returning to is a CRISPR seminar, and Jennifer Doudna is our speaker in a few minutes. And as you know, my laboratory spends a lot of time studying various models of MPN. We have little mice that get ET, and actually we've learned to prevent ET development. We study a factor that it's a chromatin regulator, an epigenetic regulator. And when we make mice with just a single allele, half the dose, they don't get myelofibrosis. Their spleens stay small, their bone marrows look great. And now we're starting to do transcriptomic analysis. So we're looking at all of the different genes that are turned on or turned off by this factor. And we can plug it into in silico algorithms and come up with drugs that mimic that. And then we test those drugs again, so far just in cell-based models, but we're getting ready to test them in our actual mouse models. And so I think there's just an immense amount of work going on in the field, and the future is very bright. And all the things we've discussed, healthy lifestyle for all of us, Mediterranean diet, sure, there's not a lot of data, but those kinds of measures I think are going to be incredibly important together with what we discover in the laboratory with CRISPR and with trials in therapies. So I think it's very promising, and I'm excited to be a part of this field.
I can't agree with you more. That's great. And so to both of you, we thank you with all our hearts. And we are going to now allow our industry partners, several of them are with us today, just to give brief updates. And we think it's very important. In fact, I just wrote an article about the importance of these three relationships. These three entities are just so important to new drug development and to learning more about the disease. And that would be you researchers and clinicians, the patients, and the biopharma companies. We can't do it without any of you, and so, or each group. And so, Jason, thank you so much for staying for 2 hours. It's good to see you. We miss you and appreciate all the work you're doing. Linda, it's so good to see you, and I'm so glad to hear your mom is doing well. Her mom was recently diagnosed with an MPN. And thank you for all the great work you're doing at Johns Hopkins. I mean, it's so invigorating. It's just great to hear from both. And so without further ado, have a great day, stay safe.
Thank you, you too.
Bye, and enjoy Jennifer. And take care, take good care of yourself.
Bye to all the patients, bye-bye.
Bye-bye, thank you.
Bye.
So at this time, I would like to bring on our first speaker from our industry partners from Pharmacentia, who you heard conversation about ROPEG interferon. Dr. Ray Urbanski is with us, and he will give a brief update on what's happening with ROPEG.
Hi, thank you, Wayne. Can you hear me?
I can hear you. I can't see you, but I can hear you.
As you know, ROPEG interferon is currently at the FDA. We're expecting our approval fairly shortly for PV. For ET, we're doing the Surpass ET trial, which is a global multi-centered study, obviously looking at high-risk patients who are resistant or intolerant to HU. It's a 2-arm study, and it's versus anagrelide. And obviously, you heard some comments about anagrelide in ET from your panelists today. Yes. It's done in about 7 countries right now. In the US, we have approximately 10 sites that are all up and active and running, and this will be on our website as well if people are interested. And we're also going to be expanding sites into Europe and Canada as well. We have been having several conversations with the MPN groups up in Canada as well to sort of expand it to that way.
Fantastic. And this is good news for you ET patients, by the way. Thank you so much, Ray. We really appreciate the update, and we're so looking forward to the FDA approval. This will be great.
Thank you.
Moving on along, we'd like to introduce Lauren Musto from Sierra Oncology. Lauren, are you there?
I'm here. Can you hear me, Ann?
I can, and I can see you. Hello, Lauren.
Hello. Good morning, good afternoon, everyone. Thank you so much for inviting us to be here today. And again, my name's Lauren Musto, and I'm the head of corporate communications at Sierra Oncology. So if you're unfamiliar, Sierra, we're a late-stage biotechnology company, and we're on a quest to deliver targeted therapies that treat rare forms of cancer. So our main focus right now is the development of momelotinib. And momelotinib is an investigational agent for the treatment of myelofibrosis. So it's an inhibitor of 3 key signaling pathways that contribute to the major manifestations of this disease. And by inhibiting ACVR1 as well as JAK1 and JAK2, we believe that momelotinib has the potential to improve anemia of myelofibrosis while also improving constitutional symptoms and splenomegaly. So we're currently enrolling patients into our ongoing phase 3 clinical trial, which we refer to as the MOMENTUM study. Now, this trial is going to compare the activity of momelotinib to another treatment called danazol by assessing the impact that momelotinib may have on symptoms, anemia, the need for blood transfusions, splenomegaly, and of course, safety of the product. The trial is now open to enrollment in 21 countries with approximately 160 sites actively enrolling, including 15 in the US. We expect the results to be available in 2022, and if the trial is positive, the regulatory authorities would then have to review and approve the product before it could become commercially available. For more information, people can visit the Momentum Trial website at www.momentumtrial.com. Thank you again, and we truly appreciate the partnership we have with you and your organization. And again, thanks for the opportunity to tell our listeners about what we're doing at Sierra. Thanks, everyone. Have a great day.
Thank you very much, Lauren, and great news there as well. This drug has been around for a while, and I'm looking forward to great successes here. Thank you very much, Lauren.
Thank you.
Our next industry partner is Protagonist, and Nora Boyer is going to join us and give us a brief update on what's happening at Protagonist with MPN drugs.
Hi, everybody. Hi, Ann.
Nora. Hi, Nora.
Thank you so much for inviting us to give this presentation. We're very honored to be working with such a wonderful organization. So Protagonist is a small company. It's publicly traded. It's a biotech company. We have about 100 employees. We're in San Francisco in the Bay Area. And we have really a broad team of scientists that are focusing on developing new treatments for rare diseases and chronic diseases. Our platform is based on peptide technology. And I have a name for our compound now. We are currently evaluating rusfertide for efficacy and safety in an open label phase 2 study for polycythemia vera. And rusfertide is an injectable synthetic peptide mimetic of the natural hormone hepcidin. We did share results in this past ASH 2020 meeting on 18 patients with PV. And now we have the ongoing phase 2 trial, which is enrolling very well. And you can go to clinicaltrials.gov for more information on that. But our intention is to plan and conduct a phase 3 pivotal trial based on our phase 2 data, showing decreased phlebotomy and improvement in iron deficiency. And because patient symptoms are so important to us, we're going to be looking at that as well as quality of life. So that's our most exciting news, is that we're going to be planning and implementing our phase 3, provided the FDA agrees.
Fantastic news. This is excellent. Thank you very much, Norm.
Thank
really
you.
Appreciate it. Moving along, Constellation is another partner of ours, and I believe someone other than Dan is going to be, oh, there you are. Hello, Hussein.
Yeah.
So please join us.
Thank you, Anne. So I'm Shangyi Liao, Field Medical Director on Constellation Pharmaceutical Medical Affairs. We are a Massachusetts-based biotech company with over 12 years of discovery and development history focusing on epigenetics and cancer biology. So our drug candidates, which were all internally discovered, are the products of our expertise in gene targeting and in diseases where gene regulation and control matters. Our lead compound is investigational BET inhibitor, pelabresib, also goes by the name of CPI-0610, that we are developing as potential treatment of myelofibrosis. Constellation is currently conducting a phase 2 clinical trial of CPI-0610 in myelofibrosis, and a larger phase 3 trial called Manifest-2 has initiated. So for more information, you can find both Manifest and Manifest-2 trial at clinicaltrial.gov, or check out our website at constellationpharma.com. We all recognize that we need new therapies for MF patients that address the areas of unmet need, and we are working hard to develop such a therapy. At Constellation, our clinical and research teams are deeply invested in the scientific approach to bring these therapies to patients. Our interest and commitment to patients and caregivers extends across the MPN community, as we have additional plans for collaborative and early stage programs that may have utility in both MF and other MPNs in the future. So I applaud this community of patients and caregivers suffering from the consequences of MPNs. It is truly inspirational for us to work every day to develop these new therapies. And a final thank you to you, Anne, and the MPN Advocacy and Education International.
Thank you so much, Sean-Lee. I really appreciate it. Very nicely done. Thank you. And we're excited. So the next, please welcome CTI Biopharma, Dr. Sarah Buckley, who will be giving their update. Dr. Buckley, Sarah, are you with us?
I am. Can you hear me?
I can hear you.
Okay, wonderful. Well, first, let me say thank you so much, Anne, and to the rest of the team there for putting on another successful clinical forum for patient education. And thank you so much for the opportunity to tell you about our work at CTI. So we are developing a drug called pacritinib, which is an investigational agent. It's an inhibitor of JAK2 and IRAK1, and it's being developed for patients who are living with myelofibrosis and who are experiencing low blood counts. And in particular, our focus is on patients with severely low platelets or severe thrombocythemia. We recognize that these patients often have more advanced disease and, unfortunately, fewer treatment options. Pacritinib has been studied in over 1,000 patients with myelofibrosis, including in 2 prior phase 3 studies. And all of our prior studies, their prior phase 3s and the more recent phase 2 dose finding study that we've done have shown efficacy, and they've also included patients with severe thrombocytopenia or platelet counts less than 50,000. And so we're actually taking pacritinib on into another phase 3 study. This will be our pivotal Pacifica study of pacritinib versus physician's choice therapy in patients who are living with myelofibrosis and who have platelet counts of less than 50,000. This study will enroll patients and will randomize them 2-to-1 to pacritinib versus physician's choice therapy, which would include ruxolitinib, danazol, hydroxyurea, or corticosteroids. And we have enrollment currently underway in the US and worldwide. And there's more information available at clinicaltrials.gov. And I'd also like to share a quick update about a pathway for accelerated approval for pacritinib. So in agreement with the FDA, we've started submitting a new drug application, or NDA, for pacritinib, specifically for patients with myelofibrosis who have severe thrombocytopenia. And we hope to have more news on that submission later this year. So our team here remains very excited about our partnership with MPN Advocacy and Education International, and we want to continue to support rigorous science and data that will bring needed therapies to patients who are living with MPNs. Thank you so much.
Oh, thank you so much, Sarah. We really appreciate it, and we're very much looking forward to the possible approval of I can never say it correctly. We're just very excited about this, and we really appreciate your update. Moving right along, we have Dr. Faye Feller with us from Geron. And Faye, are you with us?
Hi, Anne. Yes, can you hear me?
Yes, I can. Hi, Faye.
Hi, Anne. Hi, everyone. Good afternoon and good morning. Thank you for having me. And thanks again, Anne, to you and your group for conducting these forums to bring together patients, providers, industry. It's really a remarkable thing. So my name is Faye Feller, and I'm head of clinical development at Geron. We're a late-stage biopharmaceutical company developing imetelstat, which is an inhibitor of telomerase for the treatment of hematologic myeloid malignancy, including MPNs. We recently completed a phase 2 study of imetelstat in intermediate 2 and high-risk myelofibrosis patients who are relapsed after or refractory to JAK inhibitor treatment. This study, known as MYF 2001 or EMBARK, showed a potential for survival benefit and an encouraging symptom response rate. Subsequently, we've recently opened a phase 3 study in intermediate 2 and high-risk myelofibrosis patients who are refractory to JAK inhibitor treatment. This study is known as MYF 3001 or IMPACT-MF. It's an open-label, randomized control trial comparing imetelstat to best available therapy. And the primary endpoint is unique for MF studies and is overall survival. And symptom response rate is a key secondary endpoint. We are currently open for enrollment and plan on over 100 sites to be open globally. You can find additional details on the geron.com website, geron.com, as well as clinicaltrials.gov. We look forward to continuing to work with you and patients to improve the lives of patients with MF and bring new therapies.
Thank you very much, Faye, and that was great. And I've followed this drug for years, so I know how well it works, and I'm hoping that for all of these drugs, I'm just hoping for the best, and we will help in any way we can. Thank you so much. So I would also like to thank those partners that are not with us, Insight, Cartos, and Obvi, and Bristol Myers Squibb. Thank you for their support. And with Imago Biosciences, you can get clinical trial information. It's available in the chat. And we hope to see you at our next event later this month. We will be talking about a lot of different subjects that impact the MPN patients and the entire MPN community. And thank you all for joining us today, and be safe, get vaccinated if you can, and take good care of yourselves. Also, if you look at our YouTube channel for Go With The Flow, there are recipes there that we think are pretty decent and pretty helpful for those looking for better eating habits. Thank you so much and have a good day.